Hi everyone, I am Dr. Anu and I am here to make Pediatrics Simplified for you. So today we are going to discuss a very important topic in pediatrics. This is a very common topic that every pediatrician must know, and it is very useful for the PG residents, and also certain part of these topics are very relevant for your NEET PG preparation. So let's get started. All these details that is given in this video is taken from the AHA guidelines on Kawasaki disease and the recent updates. So we'll get into the video. So if you have any doubts in Kawasaki disease, you can mention it in the comment section, and also if you want further videos on similar topics from rheumatology, you can mention it in the comment section. And please give a like if you find this video useful, and also subscribe to my channel and click the bell icon for regular notification. So let's get started. So Kawasaki disease. So Kawasaki disease is an acute self-limited febrile illness of unknown cause. The cause of Kawasaki disease is not yet known, and the most common cause of acquired heart disease in children. So we know that in children most of the heart diseases are congenital heart diseases, and Kawasaki is the most common cause of acquired heart disease. It is also called as mucocutaneous lymph node syndrome. So we'll see why it is named as acute mucocutaneous lymph node syndrome. It is a medium vessel vasculitis with predilection to the coronary arteries and affects children from 6 months to 5 years. So the typical age group where we need to suspect Kawasaki disease is from 6 months to 5 years. So we'll see the clinical features. So you look at the picture here, you can see a child with a rash, bilateral non-purulent conjunctivitis, palmar erythema, maculopapular rash in the body, cracked lip, red lip and strawberry tongue, edema in the feet, and also skin peeling and perianal excoriation. So the excoriation over the genital regions. So Kawasaki disease epidemiology, the cause is unknown and incidence is nearly 25 cases per 1 lakh children less than 5 years of age, and highest relative risk in Asian children, especially in children from Japanese ethnicity. And males to female ratio is 1:1.5:1, and the predisposing factor is reported inconsistently. Coronary artery aneurysm from KD accounts for 5% of the acute coronary syndrome in adults less than 40 years of age. So coming to the pathophysiology. So we have studied that the predisposition factor and the risk factor for Kawasaki disease is not clearly known, but we know the definite pathophysiology of this disease. So it is a medium vessel vasculitis characterized by systemic inflammation in the medium-sized artery in multiple organs and tissue during the acute febrile phase. So the damage to the medium vessels happen during the acute febrile phase. So in the first phase is called as the necrotizing arteriitis. So in the first phase there is a synchronized neutrophilic process that completes within 2 weeks of the onset of fever. Then after the febrile phase it goes to the subacute or the chronic vasculitic phase. So this is when there is infiltration of the lymphocytes, plasma cells, eosinophils with fewer macrophages, and this can continue from weeks, months to even years. And then comes the last phase, that is a luminal myofibroblastic proliferation phase. So in this what happens, there will be medial smooth muscle derived myofibroblastic process. It can last up to years and it can cause progressive arterial stenosis. So you have to remember 3 stages: necrotizing arteriitis, subacute or chronic vasculitis, and the luminal myofibroblastic proliferation. Coming to the diagnostic criteria. So Kawasaki disease, the common Kawasaki disease has 5 criteria along with fever. This is called classical KD. So in classic KD you have fever greater than 5 days along with 4 out of 5 of the following. Remember it by the mnemonic CREAM. So C stands for non-exudative conjunctivitis, R stands for non-vesicular polymorphous rash, E stands for edema or erythema of the hands and feet. A for lymphadenopathy. It's cervical, unilateral, mostly seen in the anterior triangle of size more than 1.5 centimeter. M for mucosal involvement, that can be erythema or fissure or crusting. So we even saw in the picture earlier about all the features. This is just a quick revision. So you have maculopapular rash or polymorphous rash, which is non-vesicular, non-purulent bilateral conjunctivitis, strawberry tongue and cracked lips, erythema of the hands and the feet, and you have the cervical lymph node. So these are the diagnostic features of classical KD. Patient should have 4 out of 5 minimum along with fever for 5 days. So coming to other clinical feature, as we have read, KD will not just affect the coronary artery, it will affect any medium vessel artery. So it can cause myocarditis, coronary and abnormality, aneurysm, gangrene, respiratory, it can cause infiltrates in X-ray, pulmonary nodules, arthritis, diarrhea, vomiting, abdomen pain, hepatitis, pancreatitis. In nervous system, it can cause irritability, aseptic meningitis, facial nerve palsy, sensorineural hearing loss, urethritis, rashes in the groin, retropharyngeal phlegm, anterior uveitis. So all these are complications of Kawasaki disease which we have to look for. So coming to incomplete KD. So we studied about complete KD. If there is a complete KD, obviously there can be incomplete KD. It is a situation when you label it as KD when they don't fulfill the 4 out of 5 criteria. So you suspect incomplete Kawasaki disease in a child with fever more than or equal to 5 days and 2 or 3 compatible clinical criteria, or in infants with fever for more than 7 days without any other explanation. So in these children, especially in people who are experienced, if they suspect KD, they have to do laboratory investigation. So the entry point for Kawasaki disease is your inflammatory markers, that is the CRP and ESR. In this, CRP is considered to be more specific than the ESR. So if CRP and ESR is elevated, then you can do other lab features which include 6. That is anemia for age, thrombocytosis more than 4.5 lakhs, albumin less than 3, urine WBC more than 10, elevated counts of more than 15,000 and elevated ALT levels. So in this 3 or more has to be there, or we have to do a screening echo. If they show a positive echogram, then you label it as Kawasaki disease and you treat it. If not, our inflammatory markers are less, this criteria is not being fulfilled, then you do serial clinical re-evaluation. A fever persists, echocardiogram has to be done if the typical peeling develops, because we know that the peeling of the extremities is a later sign. It usually occurs in the 2nd week of the illness and not immediately. So coming to the coronary artery abnormalities. So you know that the direct complication in Kawasaki disease is involvement of the coronary arteries. So echo is the primary imaging modality for the cardiac assessment because it is non-invasive, highly sensitive and specific, and proximal coronary arteries have to be measured first, and echo can pick proximal coronary artery abnormalities easily. So it ranges from dilatation only to aneurysm of various number, sizes and characteristics with involvement occurring in the proximal segments, and then it evolves distally. So if you see here, this image shows proximal coronary artery aneurysms and dilatations, and this image shows us distal artery aneurysms in the other arteries. So we have a score called the Z score. So why is that Z score there? Why can't you just measure the absolute number? So you know that Kawasaki disease is seen between 6 months to 5 years. So based on the body surface area and the weight and the height of the baby, the size of the normal coronary itself will vary. That means that a 6-month-old baby will not have the same coronary artery size as of that 5-year-old. So you can't measure an absolute value. So you give a Z score based on the body surface area of the child. So based on that, there is a classification. So anyway, if the Z score is less than 2, it is no involvement. If it is less than 2, if it is less than 2.5 to 2, it is dilatation only. If it is 2.5 to 5, it is small aneurysm. 5 to 10 Z score is mild aneurysm, and more than 10 is large aneurysm or a giant aneurysm. If there is an absolute value of more than or equal to 8, then also it is called as giant aneurysm. So coming to the recommendation for cardiovascular assessment of diagnosis and monitoring. So echo should be performed when the diagnosis of KD is considered. Unavailability of the echo should not be a reason to delay the treatment. Coronary artery should be imaged and quantitative assessment at that dimension, and also Z score has to be adjusted. For uncomplicated patient, echo should be repeated both within 1 to 2 weeks and 4 to 6 weeks after treatment. For patients with evolving coronary artery abnormality detected during acute illness, a frequent echocardiogram has to be performed to see the luminal dimension and to see if it is progressing, and also look for thrombosis. So you see the progression, you look for thrombosis. To detect coronary artery abnormality, perform echo in expanding large and giant aneurysm twice per week. So if you find an aneurysm which is large, you have to do it even more frequently. Failure to escalate thromboprophylaxis in time with rapid expansion of aneurysm is a primary cause of morbidity and mortality. Coming to treatment, we all know the drug of choice for treatment of Kawasaki disease is IVIG. So the dose is 2 gram per kg, which is given over a single day. Single venous infusion over 2 days you can give. So within 10 days of illness or as soon as possible, IVIG has to be given. If it is after 10 days, if the patient is still having persistent fever without any other explanation, or if there is any coronary artery abnormality even after 10 days of fever, IVIG can be given. We know that if the IVIG is given, there will be abnormal elevation of ESR. So in that case, ESR is not considered as a monitoring value for response of the disease. You can monitor CRP. Administration of moderate to high dose of salicylic acid, that is aspirin, is also reasonable. ESR is accelerated by IVIG therapy, should not be used for response. And administration of longer course of corticosteroid together with IVIG can be given in high risk patient with KD, but IVIG always stands as the first drug of choice. Coming to IVIG resistant KD, you call it IVIG resistant if the patient continues to have fever after 36 hours of administration of IVIG. In that case, you can either give a second dose of IVIG, or you can give a high dose pulse steroids, or you can give an infliximab. In those cases which are refractory to this, call it refractory KD, you can try cyclosporin and immunomodulators. Coming to prevention of thrombosis, if there is no coronary artery changes, you give low dose aspirin. If there is rapidly expanding coronary artery aneurysm and size more than 10, you give warfarin treatment, that is systemic anticoagulation. Increased risk of thrombus, you give triple therapy with aspirin, one more antiplatelet and an anticoagulant. So this is the progression of the disease as we studied. This is a coronary artery. Sometimes no coronary artery changes are found. Sometimes mild dilatation, which will usually resolve on a serial echo. Sometimes the necrotizing arteriitis occur and there will be aneurysm formation. This aneurysm formation will go into chronic vasculitic phase where there will be lymphocytic infiltration. Then it will go into luminal myofibroblastic proliferation, and luminal myofibroblastic proliferation will happen and probable progression into a normal lumen or a complex stenosis. Whenever this giant aneurysm and a luminal myofibroblastic proliferation occurs, there is high chance of thrombus formation, and occlusive thrombus will lead to myocardial infarction, which can cause early death. So this is the most dreaded complication of Kawasaki disease, that is luminal myofibroblastic proliferation causing stenosis of the coronary artery, formation of occlusive thrombus and causing acute coronary syndrome. Coming to differential diagnosis, the most common, most similar differential diagnosis is measles, which will also present with a maculopapular rash. The distinguishing features are it will be a septic child with purulent conjunctivitis, pneumonia, diarrhea, other features which are related to measles. The progression of rash and the vaccination status will help you guide it. Other viral infection, staphylococcal and streptococcal toxic shock syndrome, dry hypersensitivity, cystogia, and other features including leptospirosis and Rocky Mountain spotted fever. So this is the overall view of Kawasaki disease. If you look at this table, you will get a clear view of what all you need to learn. So if you suspect KD in pediatric emergency department, you do the blood investigation. You do evaluate for infectious disease, rheumatology, cardiology, and KD team you call them. Complete KD, then you directly go to first line IVIG and aspirin. Incomplete KD team, that is the rheumatology team, will take a call whether to evaluate or not. You consider repeat evaluation. If the KD team says that currently doesn't look like KD, if the fever doesn't subside, you consider repeat evaluation. If the KD team or the rheumat team feels that it is KD, you give IVIG and look for high risk features. If any clinical echo high risk features are present, then you do intensification of the initial therapy. So what is intensification? So clinical lab monitoring of KD experts, you repeat echo in 2 to 3 days or as per cardiology, and then you intensify the treatment. If after KD, after reevaluation after 36 hours of completion of first dose, if the fever is persistent, then you intensify. So you intensify in two cases. One is high risk cases, and second thing is if the fever doesn't subside, that is IVIG resistant Kawasaki disease. Or else you discharge home, you try make it low dose aspirin. Because the child has received IVIG, you cannot vaccinate the child for next 11 months. Follow with cardiology with the repeat echo, provide KD education, and to return if any KD symptoms persist, because KD can recur. So here it's the same thing that we had discussed so far. What are the high risk criteria? One is infants age less than 6 months. The Z score more than equal to 2.5 on the baseline echo itself. So thank you for watching this video. If you have doubts on what I have discussed so far, you can always feel free to ask me, and I'll be also updating you on other topics from rheumatology and also the other very important pediatric topics that are must know for pediatric residents. So keep subscribing to the channel, and please like the channel, like the video if you find this video useful, and also share it with your friends. Thank you.